My name's Tom Winter. I'm a professor of radiology at the University of Utah and chief of abdominal imaging, and we're going to be talking about controversies in coagulation techniques. I could talk for 15 hours versus 15 minutes, and we still wouldn't resolve many of these issues because there's very little science there. I was privileged to work with an old-fashioned hematologist, Elliot Williams, several years ago when we investigated this. He was old-fashioned in the sense that he practiced just hematology, not oncology, and he taught me that many of the practices that we follow, we're following based upon we've always done it this way rather than any scientific concepts. But what I'll try to do is give you some of the more recent data in the last couple of years, and there's several areas where the literature is starting to converge and we can reach reasonable agreement on it. After this introduction, we'll go through the talk. We'll be talking about pre-procedure laboratory testing and should we distinguish between easy procedures like paracentesis and riskier procedures like deep image-guided percutaneous biopsy. Then we'll move on to periprocedural anticoagulation, and we'll make a particular example of aspirin. A major theme of this talk is that how you do the procedure is much more important than the underlying hematology, and then we'll sum up. And one point just to make here is that we're not talking about embolizing the artery of Adamkowitz in a patient in DIC. We're talking about standard biopsies and needle procedures under ultrasound guidance. Now, any vascular bed may bleed. This is courtesy of one of our hematologists who gave a great hour-long lecture on this topic at Surgery Grand Rounds earlier this year.